The main reason we operate on bunions is because they become painful. They throb, they ache, making shoe wear uncomfortable. Sometimes people have very difficulty with shoes because of them. They can also cause problems in other parts of the foot and can cause other deformities in your foot, such as hammer toes or Morton's neuromas. We don't really operate on the bunion for cosmetic reasons. It's not worth having an operation just because you're not happy with the way it looks. But obviously, a good outcome also involves giving you a foot that looks nice. So let's say that's a good bonus to have from the procedure. There are some simple things you can try before considering surgery, but often you'll have tried these by the time you've come to see me already. Wide shoes always helps, especially the toe box, the final bit of the shoe should be wider. It should be made of a softer material, avoiding any crease or seam on the actual bunion itself. You can use the silicone spacers, which some people put between the big toe and the second toe, and they can straighten the toe temporarily, and they can sometimes ease some of the inflammation in the nerve, for example, if you're getting a tingling sensation. The problem is you have to remember that the spacer doesn't correct the bunion, it wedges the first and second toe. So if you use it for a long time, it will push the second toe out, which is not ideal. Orthotics or insoles can help sometimes managing the pain of the bunion. They will not reverse the bunion. And remember, the one problem with having a bunion is that you're often struggling for space within the shoe. So adding devices such as an insole, which can be quite large and often is just robbing the valuable space that you need in the toe box. The surgery involves a few steps. The first thing we do is we make a small cut on the inside of the big toe. The cut is usually around 5 centimeters long. Through that, we shave the bunion itself. We release the contracted soft tissues. But the real correction has to come from breaking and realigning the foot. You will recall that the main reason your foot is the way it is because the metatarsal bone is in the wrong place. So we have to break the bone to realign it. We'll definitely break the first metatarsal bone, and usually we break the other bone called the phalanx over here, just to give a bit of a better cosmetic correction. We break it with a saw. It's an accurate saw which lets us move the bone into the position we want it to. But because we've broken the bone, we then have to fix it. Now we fix it with the screw. The screw is just like scaffolding in a building. It's there to support the bone while the bone mends. The screw is very small and it won't be enough to hold your bunion for the rest of your life, but the bone mends around it, and that does hopefully hold the bunion for the rest of your life. Sometimes you have other problems like hammer toes, which we've discussed in the clinic, then we may address them at the same time. The one thing people worry about a lot after bunion surgery is pain. And it'd be wrong of me to say the operation doesn't hurt. It does hurt, but we have ways of minimizing the discomfort. And usually the pattern of pain you have is very predictable. You'll definitely have, the first day is usually the most painful, and we manage that by giving you a very strong additional local anesthetic nerve block. We can numb all the nerves around the foot, so the first 24 hours is often fairly pain-free. Now that block works between 16 to 36 hours, and that's what gives you that nice relief of pain when it's at its worst. After that, there will be some breakthrough pain, and we'll teach you how to manage that with some tablet medication. It's uncommon for patients to need strong medication after 4 or 5 days. Simple painkillers, maybe at night time, or one tablet before going to bed, tends to be what patients will take for the next week or two after that. The main thing that gives you the pain is the swelling after the operation. And because we're breaking the bone, and however one breaks the bone, it will always swell because it's the way the body reacts. If you manage the swelling, you can often get the pain under control. And you'll often find patients who say their foot was very painful were either just doing a bit too much or not keeping the leg elevated enough. There are risks of surgery, and these are important to be discussed and need to be considered by you before scheduling your procedure. Swelling is a problem, but it's not a permanent problem. It's the thing that probably annoys the patients the most after the operation, where the foot will be a bit puffy, swollen, therefore a little bit stiff for some months. Now, it doesn't stop you doing things. You can still live your life normally whilst it's swollen, except your shoe wear options tend to be limited. You can often manage the swelling just by breaking up periods of the foot being down for a lot by elevation. Infection is uncommon. Mild infection can be managed with antibiotics. Very occasionally, we have to wash out an infected wound. And in my own practice, the incidence of that is about 1 in 800. Numbness can be felt after the operation, just around the tip of the toe. It means you're still moving your muscles and everything, but you may feel a bit numb. That usually gets better, and it's not felt, certainly in all patients. Any operation has a risk of DVT. Bunion surgery is considered a low risk for DVT, and I minimize the risk for yourself by getting you to move the ankle and knee early after the surgery, but also get you weight bearing very early on. Other risks include fracture or non-healing of the bone, which is uncommon, but can occur, and we can usually manage this by just keeping you protecting the foot for a little longer. In my own practice, the risk of this is less than 1 in 200. Sometimes the screw that we use can annoy you. This is something you often observe much later down the line, and if it does, then I may remove the screw. It's a much smaller procedure. It's definitely not always needed, but if it does annoy you, then it doesn't mean you have to live with it. We can just open up a small part of the incision and remove the screw. Some patients have a risk of developing what we call chronic regional pain syndrome, which can be very debilitating for the patient. It is uncommon and it is rare, and it requires quite aggressive management with medication if it happens. I'd love to say it's never happened to me, or I've never seen it in patients, but it's something that does happen every few years, and in that scenario we'll enlist the help of our pain consultant to try and manage the pain. You can minimize the risk of that yourself by being on top of the pain, but also using the foot and getting going early on. I'm often asked, will the bunion come back? And the chance of it coming back is low. If it does come back, it rarely comes back quite as bad as it is now. And the aim of the surgery is to treat it once and forever, and you never have to, hopefully, in a nice way, see me again. There is a higher risk of recurrence in patients who have surgery who are younger, who are very hypermobile, and if the foot has been left for many years and is very deformed, then even then I tend to do an operation to break and realign the bone rather than fusing the joint, accepting that the correction may not be 100%, but in that scenario, often even an 80% correction will give patients a good outcome. Getting around after the operation is actually a little easier than you think. What we do is we do allow weight bearing, but you must remember your foot is sore, so I will give you crutches. You do not need a boot. What we do give you is a shoe, and the shoe looks something like this. It's a stiff, hard shoe, which allows you to put your foot in there and also allows for the dressings. As the dressings come down, you can then make the shoe, adjust the Velcro and make the shoe tighter. It's just reassuring that patients like it. You don't need to wear it in bed, but you do want to be wearing it when you're walking most of the time. You wear this special shoe, usually if I'm just doing a big toe, for about 3 to 4 weeks, after which you can wear your own trainers. If I'm doing a lot of other work, for example, correcting your hammer toes at the same time, then I might keep you in this shoe for longer. So what happens on the day of the operation? Well, you'll be given fasting instructions, which will give you closer to the time. Your total trip to the hospital lasts 6 to 8 hours, and your actual surgery itself is 30 minutes to 35 minutes, but your trip to the operating theatre is about 90 minutes. By the time we put you to sleep, wake you up, bring you back. On the day of the operation, you will meet the anaesthetist who will talk to you about the nerve block and also about the anaesthetic. We use a nerve block because it really substantially reduces the post-operative pain and it makes the whole patient experience a lot more comfortable. Sometimes we don't use it if, for example, we're doing a spinal anaesthetic, but if we're doing a general anaesthetic, we add in the nerve block. I will see you on the day myself, and I'll take consent from you, but hopefully after watching this video, you will have understood the consent process and will have understood the risks and complications. The physiotherapist will see you, and they will talk to you about rehab mobilization, and they're in charge of that bit, how to elevate the leg, and they'll give you some guidance on that. We won't let you go home unless we feel you're safe getting around on the shoe. The pharmacist and the ward nurses will talk to you about pain management, which we'll need to get on top of, especially when the block wears off after the first day. That's the main thing that you need to know on the ward. When you get home, do elevate the leg, and I really would like you to elevate it for the first 2 weeks. Now, the reason I say that is because those who do that get a very neat, well-healed scar with less pain and less swelling. If you don't do it, of course, you'll probably get it. You might get away with it, but it is a harder 2 weeks. So what I mean by elevation is, doesn't mean bed rest. It just means sitting on the sofa or on the kitchen table, just putting the leg up so that it's not dangling down. For example, you don't want to be working at a computer with your foot down the whole day. Line up some good Netflix shows, choose the box sets you're going to watch, and enjoy the time. In terms of mental activity, I would say don't plan anything very challenging in terms of work for at least 3 or 4 days, even if you're working from home, because remember, you are on medication. If you're working from home, then after a week, you can sometimes think about starting some work, or even after 3 or 4 days. But I tend to say if you can avoid going into the office for the first 2 weeks, that is better. Obviously, this varies with individuals and jobs and the roles. And obviously, if you're a very manual role, then it will be a lot longer. I'll see you at 2 weeks. I'll check, remove the bandaging. We'll do the grand unveil. You'll look at your foot and we'll get the toe moving. And also we'll get, and I'll arrange for you to sometimes start physiotherapy if I feel it's indicated at about 3 or 4 weeks. You have the post-op shoe, which you wear until then, and then I'll move you usually into your trainers. I see you again roughly at 6 weeks after the operation for an x-ray, just to check on the healing. And then sometimes, depending on how you're doing, I might see you again in 3 months. The main thing to remember is the foot will be swollen, and I do anticipate it will be swollen for about 3 to 4 months. It's not a permanent problem, but it just means you need to accommodate it with more loose-fitting shoes for a while. To shower after surgery, the easiest way to protect their dressing is to get what we call a cast or dressing protector. These are widely available online, and you can get it from Amazon, or even Limbo is a company that does it. It acts as a seal that goes over the dressing like a giant bag, but it's better than using a carrier bag or something, because the chance of water going into the dressing is significantly reduced. If your dressings do get wet, you must contact me because we need to change the dressing. If you have further questions about your recovery from bunion surgery, do first read the leaflet on my website on recovery from forefoot correction. And obviously, if you have any other queries, then you can always email the office and I'll be happy to answer them for you. What we don't want you to do is come to the surgery on the day of the operation worried. We hope we'll have answered all your queries before that.